ಮಂಗಳೂರು ಐಎಂಎ ವತಿಯಿಂದ ನಡೆದ ಡಾಕ್ಟರ್ ಕೆಆರ್ ಕಿಣಿ ಸ್ಮಾರಕ ದತ್ತಿ ಉಪನ್ಯಾಸ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಮುಖ್ಯ ಅತಿಥಿಗಳಾಗಿ ಮಾತನಾಡಿದ ರಾಜ್ಯ ಐಎಂಎ ಅಧ್ಯಕ್ಷ ಡಾಕ್ಟರ್ ಸುರೇಶ್ ಕುಡ್ವ, ಐಎಂಎ ಎಲ್ಲಾ ವೈದ್ಯ ಸಂಘಟನೆಗಳಿಗೆ ಮಾತೃ ಸಂಸ್ಥೆಯಾಗಿದ್ದರೂ ಇಂದಿನ ಸ್ಪೆಷಾಲಿಟಿ ಯುಗದಲ್ಲಿ ಕುಟುಂಬ ವೈದ್ಯರ ಸಂಘ, ಎಎಂಸಿ ಮಕ್ಕಳ ತಜ್ಞರ ಸಂಘ, ಪ್ರಸೂತಿ ತಜ್ಞರ ಸಂಘ, ಎಲುಬು ಮತ್ತು ಕೀಲು ವೈದ್ಯರ ಸಂಘ, ಚರ್ಮರೋಗ ತಜ್ಞರ ಸಂಘ ಹೀಗೆ 10 ಸಂಘಟನೆಗಳು ಅಸ್ತಿತ್ವದಲ್ಲಿವೆ. ಈ ಸಂಘಟನೆಗಳಲ್ಲಿರುವ ಹಲವು ಮಂದಿ ವೈದ್ಯರು ಐಎಂಎ ಸದಸ್ಯತ್ವ ಪಡೆದಿಲ್ಲ. ಎಲ್ಲ ಸಂಘಗಳ ಜೊತೆ ಸಮನ್ವಯ ಸಾಧಿಸುವ ನಿಟ್ಟಿನಲ್ಲಿ ಫೆಡರೇಷನ್ ಆಫ್ ಮೆಡಿಕಲ್ ಅಸೋಸಿಯೇಷನ್ಸ್ ಫೋಮಾ ಅಸ್ತಿತ್ವಕ್ಕೆ ಬರಲಿದೆ ಎಂದು ವಿವರಿಸಿದರು. ವೈದ್ಯರ ನಡುವೆ ಪರಸ್ಪರ ಸಮನ್ವಯ ಸಾಧಿಸುವ ಸಲುವಾಗಿ ಮತ್ತು ಸಂಘಗಳ ನಡುವೆ ಏಕತೆ ಸಾಧಿಸಲು ಎಲ್ಲ ಸಂಘಟನೆಗಳಿಗೂ ಅನ್ವಯಿಸುವಂತಹ ಸಮಾನ ಕಾರ್ಯಕ್ರಮಗಳನ್ನು ಫೋಮಾ ಹಮ್ಮಿಕೊಳ್ಳಲಿದೆ. ಈ ಮೂಲಕ ಸಮಾಜದ ಆರೋಗ್ಯ ರಕ್ಷಣೆಯ ಸವಾಲನ್ನು ಎದುರಿಸಲು ವೈದ್ಯರನ್ನು ಸಜ್ಜುಗೊಳಿಸಲಾಗುತ್ತದೆ ಎಂದು ಹೇಳಿದರು. ಕರ್ನಾಟಕದ ಒಟ್ಟು ಜನಸಂಖ್ಯೆಗೆ ಹೋಲಿಸಿದರೆ ವೈದ್ಯರ ಅನುಪಾತ ವಿಶ್ವ ಆರೋಗ್ಯ ಸಂಸ್ಥೆ ನಿಗದಿಪಡಿಸಿದ ಪ್ರಮಾಣಕ್ಕಿಂತ ಅಧಿಕವಿದೆ. ರಾಜ್ಯದಲ್ಲಿ ವೈದ್ಯರು ಹಾಗೂ ಜನಸಂಖ್ಯೆಯ ಅನುಪಾತ 1:500 ಇದ್ದು ದೇಶಕ್ಕೆ ಮಾದರಿ ಎನಿಸಿದ ವೈದ್ಯಕೀಯ ಶಿಕ್ಷಣ ವ್ಯವಸ್ಥೆಯಿಂದ ಇದು ಸಾಧ್ಯವಾಗಿದೆ. ರಾಜ್ಯದಲ್ಲಿ ಪ್ರತಿ ವರ್ಷ 9,000 ವೈದ್ಯರು ಹೊಸದಾಗಿ ಸೇರ್ಪಡೆಯಾಗುತ್ತಿದ್ದು ವೈದ್ಯಕೀಯ ಕ್ಷೇತ್ರದಲ್ಲೂ ಅದ್ಭುತ ಪ್ರಗತಿಯಾಗಿದೆ ಎಂದರು.
Friends, all of us knew that family physician has a great role in the management of our patients in the society. The old glory of medical profession was mainly because of these family physicians. At those days, doctors were treated as gods. They were very much respected. However, now the day has come, doctors are highly suspected. And we have to drive out this social thinking. And we have to bring back the glory of family physicians again. No doubt, now this is the era of specialization. We don't have dearth of any doctors. To be frank, in Karnataka state, number of doctors are much more than what WHO expects. We have maybe 1:500 doctors as of now. Every year we are producing around 9,000 doctors in Karnataka itself. And as of now, registration in KMC is 1,65,000 odd. Even some of them have died or gone abroad. Most probably our ratio of patient to doctor is above 1:500. Friends, this year, and what I feel is, in our profession, what is mainly we are lacking unity. All our modern doctors are divided in different associations. IMA, no doubt, is a mother association, but all other associations like IAP, API, ASI, COXI. So many of these members of these associations are not members of IMA. So we are not united. So this year, to improve the unity, we have started an idea called FOMA, Federation of Medical Associations. That means all the specialty associations along with IMA will work as federation and at district level, and we plan for the common CMEs, common get-togethers and common socio-medical activities, so that the unity among our association will improve. Definitely, IMA Mangalore has taken a lead in this, because what I am told is, in IMA Mangalore, almost all specialists are members, and majority of the CMEs are sponsored by this specialty organization, and you have consultants association. So I expect this idea has come from Mangalore itself. Finally, IMA Mangalore has done a wonderful work this year. There are very good CME programs, very good medico-social activities. I expect that they will bag many more awards in this IMA state conference.
ಕುಟುಂಬ ವೈದ್ಯ ಡಾಕ್ಟರ್ ಶೇಖರ್ ಪೂಜಾರಿಯವರು ಕೆಆರ್ ಕಿಣಿ ಸ್ಮಾರಕ ಉಪನ್ಯಾಸ ನೀಡಿದರು.
ಅಂದು ಡಾಕ್ಟರ್ ಕಿಣಿ ಅವರು ವೃತ್ತಿಯನ್ನು ಹಾರ್ಸ್ ಡ್ರಾನ್ ಜಟ್ಕಾದಲ್ಲಿ ಆರಂಭಿಸಿದರೆ ಇಂದು ನಾವು ಕುಟುಂಬ ವೈದ್ಯಕೀಯ ಪದ್ಧತಿಯಲ್ಲಿ ರೋಗಿಗಳನ್ನು ಆಲ್ಕೋಹಾಲಿಕ್ ಡ್ರಿವನ್ ವಡ್ಕಾ ಆ್ಯಂಡ್ ಗುಡ್ಕಾದಲ್ಲಿ ಸ್ವಾಗತಿಸಬೇಕಾದಂಥ ಅನಿವಾರ್ಯ ಪರಿಸ್ಥಿತಿ ನಾವು ಇಂದು ಅನುಭವಿಸ್ತಾ ಇದ್ದೇವೆ. ಅಂದು ಸತ್ಯದ ಕಾಲ. ವೈದ್ಯರನ್ನು ದೇವರು ಎಂದು ಸಂಬೋಧಿಸಿದ್ದರು, ನಂಬುತ್ತಿದ್ದರೂ ಕೂಡ ವೈದ್ಯರನ್ನು ಗುಣದಲ್ಲಿ ಅಳೆಯುತ್ತಿದ್ದರು. ಆದರೆ ಇಂದು ಕಾಲ ಬದಲಾಗಿದೆ. ಪೇಷಂಟ್ಸ್ಗಳಿಗೆ ಅಂದು ಪೇಷನ್ಸ್ ಇತ್ತು, ತಾಳ್ಮೆ ಇತ್ತು. ಆದರೆ ಇಂದು ಅದು ಮಾಯವಾಗಿದೆ. ಇಂದು ವೈದ್ಯರನ್ನು ಹಣದಲ್ಲಿ ಅಳೆಯುತ್ತಾರೆ. ಕಡಿಮೆ ಚಾರ್ಜ್ ತೆಗೆಯುವವರು ಎಡ್ಡೆ ಡಾಕ್ಟರ್. ಯಾರು ಹೆಚ್ಚು ಕನ್ಸಲ್ಟೇಷನ್ ಫೀಸ್ ತಗೊಳ್ತಾರೋ ಅವರು ದೊಡ್ಡ ಡಾಕ್ಟರ್, ಮಲ್ಲ ಡಾಕ್ಟರ್.
ಐಎಂಎ ಅಧ್ಯಕ್ಷ ಡಾಕ್ಟರ್ ಸತ್ಯಮೂರ್ತಿ ಐತಾಳ್ ಅಧ್ಯಕ್ಷತೆ ವಹಿಸಿದ್ದರು.
So, at this juncture, you all know Dr. K.R. Kini, who is the first person to practice here after MBBS in 1920. So, he is the first person who has started some South Kendra Professional Association of Doctors in somewhere around 1930, before the inception of our IMA Mangalore, IMA South Kendra branch. So, he is the one who felt that always the doctors, if they assemble together and exchange their views, it is better for the patient and also for their profession. So he is the first person. On his name, we have, the IMA Mangalore has started this oration every year. So we are on that juncture now.
ಕಾಸರಗೋಡು ಐಎಂಎ ಅಧ್ಯಕ್ಷ ನಾರಾಯಣ್ ನಾಯಕ್, ಸಿಟಿ ಹಾಸ್ಪಿಟಲ್ ನಿರ್ದೇಶಕ ಡಾಕ್ಟರ್ ಭಾಸ್ಕರ್ ಶೆಟ್ಟಿ, ಐಎಂಒ ನಿರ್ದೇಶಕ ಡಾಕ್ಟರ್ ಸುರೇಶ್ ರಾವ್, ರಾಜ್ಯ ಐಎಂಎ ಉಪಾಧ್ಯಕ್ಷ ಡಾಕ್ಟರ್ ಕೆಆರ್ ಕಾಮತ್, ಮಂಗಳೂರು ಐಎಂಎ ಕಾರ್ಯದರ್ಶಿ ಡಾಕ್ಟರ್ ಸದಾನಂದ ಪೂಜಾರಿ ಖಜಾಂಚಿ, ಡಾಕ್ಟರ್ ಕೆ ಭಟ್ ಸಂಕಬಿತ್ತಿಲು, ನಿಯೋಜಿತ ಅಧ್ಯಕ್ಷ ಡಾಕ್ಟರ್ ವೇಣುಗೋಪಾಲ್, ಡಾಕ್ಟರ್ ಚಂದ್ರಣ್ಣ, ಡಾಕ್ಟರ್ ಕೃಷ್ಣ ಪ್ರಸಾದ್ ಉಪಸ್ಥಿತರಿದ್ದರು. ಬಳಿಕ ನಡೆದ ನಿರಂತರ ವೈದ್ಯಕೀಯ ಶಿಕ್ಷಣ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಕ್ಯಾನ್ಸರ್ ಚಿಕಿತ್ಸೆ ಅಂದು ಇಂದು ಎಂಬ ವಿಷಯದ ಬಗ್ಗೆ ಡಾಕ್ಟರ್ ಹೇಮಂತ್ ಕುಮಾರ್,
More importantly, the survival has changed drastically. With the availability of these agents, probably what would have been survival metastatic breast cancer of 2 years maybe at max, 2.5 or 3 years maybe at max, it is crossing almost 5 years easily. So this has changed significantly in the terms of metastatic breast cancer. When I look at early breast cancer, this is a 58-year-old lady who had presented with right breast mass of 3 months duration. Biopsy was positive. She was ERPR negative disease and HER2 positive disease. HER2 positive disease is considered as an aggressive biology disease. On clinical examination, it was a T2N1, probably would have thought this is an early stage disease. However, in a HER2 positive disease, we try to get a PET CT done when feasible. Why? Because the possibility of having the upstage in the disease is pretty common. So she had a 2.6 centimeter primary, 3.1 centimeter axillary node, large axillary node, and she had a 1.3 centimeter same side supraclavicular node. Remember, in CA breast, the ipsilateral supraclavicular node doesn't make it a metastatic node, but it upstages the nodal disease to N3C.
ಕ್ಯಾನ್ಸರ್ ನಿರ್ವಹಣೆಯಲ್ಲಿ ವಿಕಿರಣ ಚಿಕಿತ್ಸೆ ವಿಷಯದ ಬಗ್ಗೆ ಡಾಕ್ಟರ್ ವೆಂಕಟರಮಣ ಕಿಣಿ.
So the overview of what I'm talking, firstly what is radiation therapy, then the types of radiation therapy, role of radiation therapy in various malignancies, the side effects, and some of the myth busters. Firstly, what is radiation therapy? The myth is it is current treatment, shock treatment. This is what most of my patients think when they enter my chamber. ನಮಗೆ ಇದೊಂದು ಕರೆಂಟ್ ಒಂದು ಬೇಡ, ಇದು ಯಾಕೆ ಬೇಕು, ಇಂಜೆಕ್ಷನ್ಸ್ ಇಲ್ವಾ, ಸರ್ಜರಿ ಆಗೋದಿಲ್ವಾ? ಬಟ್ ದಿಸ್ ಇಸ್ ನಾಟ್ ವಾಟ್ ವಿ ಡೂ. The fact is we treat using ionizing radiation. You can see the patient is sleeping peacefully on the machine and it rotates, something like a CT scan. And what is this ionizing radiation? I told we treat with ionizing radiation. So this ionizing radiation is a part of the light. It is something beyond the visible spectra. And you can see the UV rays which come from the sun, that is also an ionizing radiation, and that can cause skin malignancies. Similarly, X-ray machines, they also have ionizing radiation. CT scan with slightly higher energy, and then our therapy machines, they have even more higher energy. And then the other myth about the various cell phones and all that, are they ionizing radiation? No, the radiation from cell phones are not ionizing radiation. Otherwise you could treat by just keeping mobile next to the patient. They are non-ionizing, but will they cause cancer? As of now, there is no proven data for that. In future, we don't know what the studies will come out with.
ಕ್ಯಾನ್ಸರ್ ಚಿಕಿತ್ಸೆಯಲ್ಲಿ PET CT ಪಾತ್ರ ವಿಷಯದ ಬಗ್ಗೆ ಡಾಕ್ಟರ್ ಯಶಸ್ವಿನಿ ಕೀಳಂಬಿ ಉಪನ್ಯಾಸ ನೀಡಿದರು.
So we'll see what is PET CT, what is the mechanism of action and applications of PET CT. PET stands for positron emission tomography. For this purpose, we use radioactive elements which will emit positrons, which are positively charged electrons, which will eventually be picked up by the scanner, and the images are reconstructed and we can view the images. This is a PET CT scanner. It's an hybrid imaging, PET as well as CT. So there are two rings in the gantry behind. This is the gantry, this is where the patient will lie down. So in one go we can take acquire PET as well as CT scans, fuse them and then review the images. We call it a tracer, not a contrast. In PET nuclear medicine we call it a tracer because it traces the physiological process in the body, like glucose metabolism for fluorodeoxyglucose, and prostate membrane antigens will be targeted by PSMA, as well as serotonin receptors by DOTA agents. So major mainstream is F18. All of you already know FDG. That is a mainstream. There is also gallium-68, gallium PSMA, etc. There are other tracers also which are used for other purposes, more in the research and academic orientations. So this is, I think all of you will recognize this one. This is essentially an MIP image of a PET, maximum intensity projection. Here you can see brain uptake, heart uptake, some mild diffuse liver uptake is there, and urinary bladder distribution is also there. This is physiological, and you can see compared to the previous one, there are dark spots here. That is the malignant or infective or inflammatory uptake of PET. So applications for staging, it's pretty straightforward. Primary and local infiltration, lymph nodal and distant metastasis. That we won't see much. It will be useful for restaging, response assessment, and more importantly, treatment modification. This is just to show you the value of PET CT. In lung CA, you can see the high sensitivity and specificities of FDG. Essentially, it will be similar in all other scans, because all other cancers, because all the tumors are glucose hungry, so they will take up more FDG. This is a pretty straightforward case of CA breast. Patient presented with complaints of swelling in the left breast, increasing over the past few months, and biopsy was done. This is how it will look on the PET CT image. You can see the increased uptake of FDG in the lesion. It's rather a multifocal lesion. Two lesions are there with axillary lymph node metastasis. Now, more importantly, there is recently we have something called as PET guided biopsy, and its advantages over standalone CT we can see here. This is a case of CA lung. We can see the increased FDG uptake here, surrounded by non-FDG avid consolidative changes in the lung. So essentially, if you can see just the CT image, it all looks fairly similar. So for example, if instead of going for the biopsy in this area, looking at the CT, if we had gone in this or in any other area, we would get a negative result. So this way, PET CT will be useful for guiding the biopsy. Not just CA lung, for example, in a case of lymphoma also, if there is a high uptake will be there in some of the nodes, low uptake will be there in some of the nodes. We can see in the scan, and I can suggest the oncologist where to get the biopsy from, which might turn out to be mostly a positive result. And this is another case. CA breast, it's post-operative case, post-chemotherapy, radiotherapy, everything was done. Patient came with a back pain. Patient has a multiple lesions, metastatic lesions in the spine, vertebral column. Of course, there are multiple sclerotic lesions also. But here, what I want to show you is there is increased uptake in the bone marrow, because on CT image, there is no uptake at all. There is no anatomical lesions at all. But however, on PET CT, we can see increased uptake. So this is one of the other advantages. And this is a case of any solitary pulmonary nodule. You all know that solitary pulmonary nodule, depending on the size of the nodule, the chance of malignancy will differ. However, if there is increased FDG uptake, it is highly likely that lesion is metastatic. FDG has around 91% sensitivity in solitary pulmonary nodules.